morning, everyone. Good that you could join us again. I hope you had fun last night. My name is Jeroen van der Ham. I'll be the session chair this morning. Before we begin, please make sure that you silence your devices, that we can pay attention to the speaker. The speaker today is Tom Millar. Josh Corman unfortunately couldn't join us this week, but I'm sure that he conveyed all of the input that he had to Tom, who can present this in his known manner. He's been a speaker at FIRST conferences for many times, has been a good contributor to the FIRST community. So please welcome Tom Millar.
Good morning, and thank you all for coming today and getting up on Thursday when things are starting to get a little hectic around here. So yeah, this presentation is specifically about the COVID task force that we established at the Cybersecurity and Infrastructure Security Agency where I work, and how we work together to support the response to the pandemic. So let's start a little bit with what is the Cybersecurity and Infrastructure Security Agency. Oh, and I should say a couple of things right up front. One, if you have a question at any time during this presentation, go ahead and approach the microphones, and I'll try to acknowledge you and make time for your questions. That is fine for me to do that in line, because I like my presentations to be as interactive as possible. The other thing is, if you know me fairly well, I despise PowerPoint, but I have lots of graphs and other things and other data points that we need to share as part of this presentation, so I was forced to delve into my nemesis and generate a presentation. Not only that, but I've got 28 slides today for a 35-minute talk, so I'm going to be flying through this at a clip, and I apologize in advance for that for any of you who may get lost. So again, please go ahead and ask questions at any time, and it'll be available online, so you can just pause and rewind and try to catch up if you get lost. So CISA, as we pronounce it, is the, not CISA, not CISA, is the nation's risk advisor, and in parentheses we also say and reducer. We are not a cyber regulator. We don't have law enforcement authorities. That's why we say we're the risk advisor for the nation. And when you say risk advisor, we mean all different types of risks, not just cybersecurity ones. So we have infrastructure security and emergency communications responsibilities. We also have a national risk management center. And as you can see, we have a couple of other divisions that also work with us to support various functions. And we are the GovCert and the National CERT for the United States. This is a timeline of the stand-up and eventual handoff of the CISA COVID task force. Now, this is going to be a little bit confusing because I'm sure some of you probably participating in the Sec Lounge Capture the Flag Challenge. For the purposes of this presentation, CTF means the COVID task force. So, trying to make sure that's clear. So the COVID task force was sort of established as a result of the Coronavirus Aid, Relief, and Economic Security Act that Congress passed very early on in the pandemic. You'll see, this is, by the way, this graph is the COVID-19 case graph generated by the Centers for Disease Control in the United States. At the very beginning, you see there in January, that is patient 0 in the US, all the way to the spike after Omicron appeared, and the task force was not, the task force was sort of like transitioned to steady state operations rather than being a task force. In between, you have the establishment of Operation Warp Speed, some of you may have heard of. That was our effort to fast track a vaccine as quickly as possible. You'll see when Mr. Corman was initially recruited as a temporary hire to CISA to support us, and when he was able to join us as a fellow federal employee. In October of, what is that? making sure I get this right. October of 2020 is when we released a joint report with our colleagues at Healthcare and Human Services and the Federal Bureau of Investigation regarding ransomware activity targeting healthcare. The generation of the CTF combining both career and CARES Act temporary hires, and one of our publications, the Cold Chain Insights series, which we'll get to in a little bit what that is. You'll see a big gap there, right? It looks like we didn't do anything for a while in the middle. I will assure you that was not the case. We were extremely busy, but I could only fit so much on my timeline graphic. And the other thing is there is so much stuff going on in that range. We're going to spend the rest of the presentation talking about just some of it that we supported. So here's the breadth of what we were dealing with. This goes all the way from the very beginning of R&D, where we were mostly concerned with sort of the intellectual property of the vaccine companies being protected from espionage, things of that nature, all the way to the end. We were worried about disruptions anywhere in the supply chain that could lead to, even if we had a great vaccine candidate, was there anything that could stop it from actually getting into people's arms? And as you can see, there's plenty of opportunities along the way throughout that supply chain for a disruption to happen. And we were trying to figure out, okay, where can we prioritize our efforts best to help? So we'll get to that as well. So you'll notice up here I say ball bearings. Has anybody studied has anybody studied history and knows perhaps what the ball bearings reference might be? Okay, got one hand back there. So World War II, there was an effort, like where should we bomb first? And the idea was, well, we should bomb the factories that make the tanks. We should bomb the factories that make the planes. The answer is none of the above. The answer is bomb the factories that make the ball bearings, because then you can't make tanks or planes. So we looked at it from the other perspective, from the defender's perspective. Where are our ball bearing factories in this space? So we know that Operation Warp Speed, or what we called Tier 0, when we got a little bit more expanded beyond the original Operation Warp Speed institutions, Tier 0 was all the R&D stuff. So that was universities, that was obviously the big Pfizer and Moderna vaccine companies and pharmaceutical companies, and everything that was critical to the mass manufacture of the vaccine. Tier 1 is what we called the other 100 organizations that, if we step back in the slide, you saw the icon of the warehouse, the icon of the truck, the icon of the cardboard box. There were all kinds of organizations that we also needed to support to make sure that supply chain was secure. And then finally, this one's near and dear to my heart, and once again, we'll get to that and why, but healthcare delivery organizations, as we call them, which is hospitals, clinics, hospital networks throughout the country. And in the United States, depending on who you ask and who took the sort of census of how many healthcare delivery facilities there are, it's somewhere between 5,000, 6,000, usually closer to 6,000 at least. So that's a lot. We had a lot of ground to cover. So thinking about this ball bearings metaphor, so first we were tasked, let's make sure vaccine R&D is squared away, right? We want to make sure development is going to be safe. But where is the disruption really going to happen that's going to affect things next? And that's why we started looking at, almost immediately as we hit the ground running, as the COVID task force was formed, we started looking at, what is necessary to scale production of the vaccine? Where can we start to deploy services or tools or resources or advice or guidance, and make sure that these companies and institutions are aware of what we can do to help them reduce their risk in the scale production area. And finally, focusing on distribution, and this is where we started talking about what we called the cold chain. And the cold chain is everything necessary to get things from one place to another in a refrigerated state, sometimes a very extremely cold refrigerated state. Which we knew once we figured out that the vaccine candidates were going to require refrigeration, we had to look at all the different things, the chemicals required, the types of logistics required, and all sorts of other aspects of that to make sure that the vaccines would get to where they needed to be in the condition that they needed to be in. So that's how we approached the problem set. This is how we formed the team. I'm not going to read you the slide, but I do want to focus on one thing. I mentioned earlier when I was explaining CISA that we have 6 divisions, all focused on supporting different specialty areas within the mission and enabling functions. So we worked across nearly every division within CISA, and I actually probably shouldn't have even put nearly on this slide. It was every division across CISA in the end. So, and we reported to our executive director, who is the most senior ranking career official in the organization, and that was because basically because we also had to do this in the middle of a administration turnover. So all kinds of exciting things happening, right? This is an example of the type of stuff that we were doing in that big trough that you saw on the timeline. This is one of our analysis products that actually made it into a very prestigious medical journal. So in February 2021, we hit the unfortunate milestone of 500,000 people perished from COVID, but 150,000 people perished from other causes. And that's not to say, like, how do I put this correctly? Excess deaths. So the CDC knows pretty much more or less how many people are going to die in any given year from various causes, right? But if that number is exceeded by a certain amount, then you start to look into there, why are more people dying than we thought there would be? And so they have a number called excess deaths, and excess deaths hit 150,000 in February 2021, and we started looking and you're like, why is this happening? So we dug into the data, the case data, and again, you're like, I thought this was a cybersecurity talk. No, this is an analysis talk and a risk reduction talk, and we're going to get to cyber aspects in just a little bit. Promise, just bear with me. So we dug into the data from the CDC, and we used our analytic tool set because the CARES Act hires brought us people from intelligence, brought us people from medical backgrounds, brought us people who really understood all that supply chain stuff, a multidisciplinary team, and we put that together to work on this problem. We made the weekly morbidity and mortality report from the Centers for Disease Control, which is one of those things where they expect you as a corresponding author to have a medical degree, and we're like, none of us have medical degrees. We just looked at the data and determined that definitely there were excess deaths resulting that were not expected. And this is all the stuff that was in this insight, so I'm going to delve a little bit more into the analysis. You can probably understand this because it's a network graph, but it shows the degradation of service over time for healthcare delivery organizations as strain is applied to the system. So normal operations in non-pandemic years is obviously on the left. You add maybe, a couple of overwhelmed hospitals or clinics. Ambulance starts to redirect to different centers. It adds strain to the system, and then maybe one of them gets hit with ransomware, knocks that one out for however long, and the system continues to degrade. And here's the different things people were dying from. These are what people were perishing of in addition to COVID, or excluding COVID. These are all the numbers. The thing you need to know about this, without digging into it too much further, is that these are heart, lung, and brain problems. Heart, lung, and brain. Remember that because we're getting into it in a second. And this I wanted to show you because this is who, demographically who is perishing in excess of what was already predicted, and excluding COVID-19 too. So when we look at this, we dig into the data a little bit more. We can see that adults in their prime working years are perishing in these excess death counts and from COVID as well. So it's like, what is the risk to the nation? What is the risk to our essential critical infrastructure workforce, right? That's right there. And now we're going to get into some fun cyber stuff. We started looking at what could happen to our ability to administer healthcare in case of that ransomware targeting that we talked about earlier. I want you to take a look at the southeast half of this circle up here. That's your radiology and your imaging, your electronic healthcare records in your laboratories. If you don't have any of those three things, or you're just missing one of those things, there's tons of stuff you can't do for people anymore. If you miss EHR, you can't give cancer patients their appropriate chemotherapy dosages. If you miss laboratories, you can't run labs. leave it to you to do the math on what that implies. And if you don't have radiology, you can't treat stroke patients because you don't have imaging to find out where the problem is. And here, so this says conceptual, but this is based on a real live incident. And as you can see, it took basically 6 months to get back fully online for all services to be restored. So that's a really long time for a hospital to be unable to deliver care. And we know this based on real events that happen. And again, a conceptual model, but there's real analysis to back this up based on real world things, and we basically did connect the dots exercise. So you have a ransomware attack or some other disruptive type of cyber event, drops the network, drops your ability to access services. You start to divert ambulances because you can't provide services now. You divert those ambulances 5 minutes. People with certain conditions like brain, heart, and lung can be negatively impacted by that. You start to divert it by 15 minutes. Again, brain, heart, and lung. There's a golden hour for these types of things, you know? And once you start to divert like 90 minutes out from wherever the patient is, and here's where we found the original analysis of this was about marathons and their impact on patient outcomes. Marathons cause ambulances to be diverted because huge, stretches of city streets will be blocked off, and ambulances will need to divert around the marathon route or route. And once they arrive, they're going to be a little bit later than they normally would be. So people took this data, did the analysis, and said, okay, this has a negative impact on patient outcomes. And so we took that analysis and we did the connect the dots exercise, and we basically determined you combine that with the hospital strain we're already dealing with in the pandemic, and add a ransomware attack to that, and you're going to have an increase in delays to service, and delays to service cause increased numbers of deaths. So we're like, this is what we're dealing with. This is the problem we're trying to tackle. So now, how do we start to address all of this? We know there's 6,000 hospitals. We can't do one-on-one outreach with every single one of them. We know there are these hundreds of organizations that may or may not know that they are part of a critical supply chain and that we have resources that can help them. And what we kind of determined about a lot of the organizations that we were trying to assist is that we considered the environment to be target rich. We also considered the environment to be mostly cyber poor. A lot of immature programs at these organizations. How can we help them? So we started developing things like this, the bad practices. I strongly encourage all of you to, instead of trying to read this screenshot, go ahead and just like Google or use your favorite search engine and hit up CISA.gov and search for bad practices, or just type CISA bad practices. It should pop up as one of the first hits. There's only 3 of these. It's really simple. Everybody knows best practices, and there's hundreds of those. Bad practices, we made sure it was a very, very short list, and they're really simple. Don't use end-of-life or unsupported software. Don't use single-factor authentication for administrative or remote access, and don't use weak, fixed, or default passwords. And for critical infrastructure specifically. So we made this as a way to get people in the right mindset of, if you're doing these things, you are low-hanging fruit for the adversary. Bad guys love when people do these things, so please stop doing them or figure out a way to get out of that practice. We created stuff off search. Now, I will say, leave it to your imagination what the original name of this was when it was a little bit less polite. But stuff off search was, everybody's familiar with Shodan and Census and Thingful, more or less. So yeah, we basically created a do-it-yourself guide to getting your stuff off of those search engines so you can manage your attack surface better. Because once again, what do we know about the bad guys? They love finding stuff on these things, and they use these tools as well. And we also have our known exploited vulnerabilities catalog. Who is already familiar with this? Awesome. Okay, seeing a lot of hands. So this is our list of all the, not just the CVEs that are, the CVEs that are most severe or highest scored or any of that, but the CVEs that we know adversaries are using against targets that we have observed in the wild being employed. And so this is the shortest possible list of every must-patch vulnerability in your environment. Once again, to try to help these organizations with less mature, less well-resourced programs to prioritize those scarce resources better. And we created a webinar. This is another thing I do encourage you to take a look at. You'll get to see my colleague Josh Corman introducing the Pragmatic Cybersecurity webinar, and you'll also see some of our colleagues from the CARES Act staff who were part of the COVID task force that I got to work with. Anyway, we talk about the bad practices, we talk about the stuff off search, and then we talk about our tabletop exercise packages. So CISA has a long list of tabletop exercise packages for any type of organization to use at their leisure. And we've been trying to encourage more and more organizations to say hey, if you're starting your program or you don't have an exercise program yet, go ahead and download some of these and start using them, especially for example, the ransomware module. So let's delve in a little bit more deeply into what we did for each of these tranches of, or categories of organizations that we were helping. For Tier 0, that's for the smallest number of institutions that we were trying to look after, we were able to do some of the things that don't scale very well. So we did our full red team assessment services for them. We provided our cyber hygiene assessments, which I'll probably describe a little bit more. Or you can just come ask me later about the cyber hygiene services that we provide. We did some special enhanced information sharing, especially with our partner agencies, to make sure that these folks had the best threat intelligence and other information that they could use. And we did a program called Cybersecurity, and we applied what we call persistent threat hunting. So persistent threat hunting is continuous, right? Most people are familiar with the idea of a hunt engagement. You go in, you look around, and then you take your taps and you go leave and go look around somewhere else. This was persistent threat hunting, one of the most unscalable things we do. It's extremely resource intensive, but we made sure to do it for the Tier 0 family of institutions. Tier 1, right? This was the one that was about 100 organizations, so we obviously couldn't scale all of our services to this, but we did do one-on-one outreach. And I got to tell you, I'm not a salesperson, but I did a big chunk of these companies because I got the California region and a few other West Coast were assigned to me, and man, I was extremely thankful every time a lead turned into somebody who actually wanted to talk to us about services and resources. I'll just put it that way. It's not fun necessarily cold calling people who don't know what your agency does or what your agency's mission is and saying no, free stuff from the government. I'm from the government. I'm here to help. Not everybody is completely receptive to that, but we were able to get some penetration. We did get good leads. We got to the right people, and we made a difference. And these are the services. I'm not going to read all of these to you. You can search for them and check them out at your leisure. And HDOs. And this one, we couldn't do one-on-one outreach, so we're like, how are we going to start trying to target this entire community? The answer was we hit the national level associations and communities there. So there are things in, I think there's some global organizations like Healthcare Information Management System Society. There's some US-based domestic organizations like the Joint Commission. We reached out to those. Those in turn gave us opportunities to do webinars targeting different parts of the healthcare ecosystem, and that's how we made sure that they were aware of all these different resources that we have available, and share those with those entities. And this is ongoing, continuous. This will probably never end because all the way back to that thing about ransomware and ambulance diversion and how it can lead to excess deaths or contribute to greater than normal excess deaths, that's not going away. We've determined that conclusion because of data that we were able to analyze and analysis we were able to conduct during the pandemic. But even when this pandemic is finally over, or at least in some more steady state, even when that's all over with, this is going to be a continuous issue. Just a little bit about some of the cross-sector analysis we were able to do. I discussed the cold chain discovery. Like, we learned so much about the cold storage supply chain and cold logistics. That analysis on hospital functions and effects on services is going to be paying dividends for a long time, I hope. We learned more about strains on what CISA calls the national critical functions. We learned more about strains on, the cascading effects on critical infrastructure sectors, especially as that essential critical infrastructure worker force was depleted due to illness or other excess death problems, et cetera, et cetera, et cetera. There were supply chain disruptions. I think everybody experienced that to one degree or another. We learned about how those supply chain disruptions were impacting other things. And also, like I said, the risks to the ECIW, as we called it, that workforce. Here's what worked, and here's the lessons learned for everything. Collaboration across the divisions between cyber, national risk management, stakeholder engagement, the integrated operations division, all of the different divisions working together. The collaboration was enabled by that task force and the prioritization of the work. A crisis is a great time for pilots, you know. It's like, have we tried this before? No? Well, it's pretty important, so let's try this now, right? This is a great time to take risks and do things, or you know, sort of like take some adventurous thinking and use your imagination. And we were able to do that as well. We did some things that otherwise wouldn't probably be a standard operating procedure. Let me just put it that way. You know, we started this whole outreach to national level associations for healthcare delivery organizations because of this pandemic, right? And that's that ongoing continuous work, and that's going to be a great benefit to our country and society. And international sharing was also, we had some international partners who were kind of leading us with the data, so we would see what was happening in another country and be like, oh, is that about to happen over here? We also had to go the other way, where some things happened in the United States. We shared the same data with our international partners, and they were able to determine that they were about to, you know, face the same risk and that they need to prepare to tackle it. These are the things that need work. Most people still don't know what a CISA is or what it does. We are a relatively young agency. We have to constantly explain ourselves like, hey, remember US CERT and ICS CERT? Yeah, CISA now. Still doing all the same stuff and then more. Right-sizing the service catalog, right? We had all these different sort of categories and populations that we're trying to reach to and deliver what was the best fit for purpose for their needs. We learned a lot about our service catalog not necessarily being like the best thing ever, and that we needed to make sure to tune it up for the audiences we were trying to serve. Build more capacity for incident response and support. I think that does what it says on the label. And when I say administrative experts, the people that make all the other gears turn, right? We had lots of these extremely clever people with all sorts of great backgrounds and experience. But what we really needed most sometimes were people that just knew how to navigate the bureaucracy, to get things done, and to keep the rest of us on track. So it's not just, you know, to have really thoughtful, intelligent people with a, you know, powerful education and lots of experience isn't necessarily the be-all, end-all. You also need people who just know how to make things work. And muscle memory is something that's really important to me, because as part of the COVID task force, what we determined was we need to remember how to do this for future task forces. How are we going to keep these trust connections in place between all the different divisions, between these multidisciplinary teams, and with our partners like at Healthcare and Human Services? All right, question. I noticed nobody walked up to the microphone, so that means I must have done an outstanding job. Yes, sir.
That was great. Just a quick question on when it came to your cold calling and outreach. How did you do lead gen for such a diverse kind of group of stakeholders, and what did the ideal candidate for conversion look like? Like, who had the resources to uptake your offer of help? Because presumably there was some work required on their end.
So lead generation was social media, LinkedIn, know a gal who knows a gal kind of thing. So there was like, we used basically like, we had a multidisciplinary approach. No, we used every tool at our disposal to do lead generation and try to find people in the CISO shop or the IT team, or sometimes in the case, depending on the size of the business, we'd go straight to the CEO. And if we did get the CEO, we tried to make sure that they were talking to an equivalent level within our organization. Obviously, we don't want, like little old me talking to the CEO or founding father of a company or something like that. Ideal candidate is a tricky question. Honestly, we were looking for anybody that would listen, and then we would try to tune the services to meet them. So when I talk about our cyber hygiene services, for example, there are 4 of those, 3 or 4 services that we can provide at scale to almost anybody. What we do is start them with simple attack surface management stuff like vulnerability scanning, and get them to, like, hey, give us an IP range. We can help you start your asset management program by at least telling you what's on your perimeter and where the CVEs are, and we'll tell you which of those CVEs are on the non-exploited vulnerabilities catalog. And then if you turn out to be able to take that information and act on it, because again, like week by week, we can see who's patching what, or at least mitigating. And we say like, hey, are you interested in web application scanning? Are you interested in a phishing assessment? Things of that nature. And that's kind of standard operating procedure. That wasn't even necessarily special for this effort. In the back, yes, sir.
Morning, Tom. Thanks for the presentation. As you know, I'm in the healthcare. So one of the things that we find is that trying to do and not allow end of life for MRI scanners, CAT scanners, when they're, first of all, a lot of these doctors don't even know that there's a computer in these things. And these things cost $2, $3, maybe $4 million. If I'm a small hospital or even a big government research organization, I'm not taking that money out of my operating budget to fix them just so, and not be able to do my mission. So what I would love for you to do, CISA to do, is help us figure out ways to mitigate these issues without putting them behind a VLAN where people can't access them, because most of these organizations need to monitor them remotely because they're not going to be sending people, technicians to all these different hospitals.
Yes. I mean, I really love this question. I really love because this is the difficult conversation that we need to have, right? CISA needs to have that with the community as well about like how do we deal with end of life in healthcare for especially the types of systems you're talking about. The stuff where rip and replace is not an option at all. It's off the table. The VLAN's not a great option either. And so what do we do to mitigate the risk given all of that? And that's why, like to draw the line in the sand, so to speak, about end of life and call that a bad practice and make it number 1 was specifically so that we can start the hard conversation about what do we do to mitigate that risk when, the most straightforward options aren't on the table initially. So do you want, can we talk about that offline some more and maybe start some correspondence as well?
Yeah, just contact me, and we need to get all of NIH involved because we're all feeling the same issues, and we can help you with the hospitals, and at least because we have the experience.
Great, thank you very much. I look forward to it.
Thank you for your presentation. It seems like a tremendous effort. It was very interesting. I had one question. I was really interested by this whole cold chain action, but I was wondering what measures you took for the supply chain of that tier 0.
The tier, like, can you maybe rephrase that? I'm not completely sure I understand the question.
My understanding is the tier 0 is the big producers of the vaccine, right? And I'm sure they have a bunch of relationships with other companies or suppliers, and I was wondering how you looked into that.
Yes. You like, how did we analyze what those supply chains were?
Yeah.
That's where the multidisciplinary approach really helped out initially. was by getting the right people on the team, people who had run hospital networks before, for example, was one of them. People who were from healthcare and human services, had a background there, and knew like how, various, pharmaceutical grade things are produced and how they get to the Pfizers and Modernas of the world, et cetera, or to academic institutions doing R&D. They were the ones instrumental in helping us identify, like, boom, 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 boom. This is what tier 0 needs to consist of, and then spreading that out to tier 1.
Thanks.
Do we have time for one more?
Oh, great, because I got 2. Very quick. Thanks, Tom. Great stuff. I'm glad to see my tax dollars at work, and it'd be great to advertise all the good stuff so that the rest of the taxpayers of the country would know that. 2 things. One on the persistent threat hunting. Just curious if that was, what kind of results you got from that without getting into details. And the other question is on the study showing the excess deaths and the contributions that a ransomware attack would make. Are you aware of, or are you aware of people thinking about using that in prosecutions? When you have attribution, somebody who's actually put in jail, and using that as an enhancement, for example. And you did ransomware, but you also probably killed this many people while you did it. Thanks.
These are short questions because no, I can't talk too much about what we found with persistent threat hunting. I apologize. But the other one is also, no, I am not aware of anybody using that analysis to support a ransomware prosecution, but that does certainly sound interesting.
All right. Thank you very much. I forgot to remind you at the beginning of the session that this session is TLP white, so you can say whatever you want about this on social media, etc. But please thank the speaker for this wonderful presentation.